Imagine a tumor that reaches the size of a grapefruit, maybe 8 to 10 centimeters in just, I don't know, 12 to 24 weeks.
And doing all of that without triggering a single sensory pain receptor.
Right, exactly. The patient just goes about their daily life completely unaware that a high-grade malignancy is rapidly expanding in the deep muscle beds of their thigh.
Yeah, it's in there building its own vascular network, metabolizing energy at just a staggering rate.
And by the time the mass is physically palpable or, visible to the patient, the biological clock is already ticking loudly.
Oh, very loudly.
So, welcome to our deep dive. Our mission today is to dissect the clinical, microscopic, and, well, the molecular realities of a highly aggressive and incredibly elusive tumor for you.
Yeah, pleomorphic liposarcoma, or PLS.
Right, PLS. And we're stepping into a multidisciplinary tumor board today. We're using the authoritative WHO classification of tumors to guide this deep dive, really bringing together the surgical, pathological, and oncological perspectives.
It's a complex landscape, to say the least.
It really is. Okay, let's unpack this because PLS accounts for less than 5% of all liposarcomas.
Yeah, less than 5%.
So we are dealing with an outlier within an already rare category of soft tissue sarcomas.
We are. And looking at the demographic data from the WHO guidelines, this is a disease that predominantly targets older adults.
Right, usually in their 60s or 70s.
Exactly. The incidence peaks in the 7th decade of life, and there's a slightly higher prevalence in males. And it's exceptionally rare in the pediatric population.
Wow, okay.
But the defining clinical feature is exactly what you opened with the presentation. It typically manifests as a rapidly growing painless mass.
And usually in the arms or legs, right?
Mostly the legs. 2/3 of cases occur in the extremities, specifically favoring the lower limbs. And while about a quarter of these tumors develop in the subcutaneous tissue, the vast majority arise deep, like deep within the soft tissue.
And the timeline is just terrifying. I mean, the median preoperative duration, the time from when the patient first notices an abnormality to actual surgical intervention, is remarkably short.
Usually just 3 to 6 months.
Which is wild. That 3 to 6 month window paints a very specific physiological picture. I mean, a mass expanding that quickly without causing pain suggests it's initially pushing along fascial planes rather than overtly invading nerve plexuses.
Right, it's taking the path of least resistance at first.
Exactly. It operates like a stealth bomber, just bypassing early sensory detection entirely.
That's a great way to put it.
But a tumor achieving an 8 to 10 centimeter diameter in a matter of months requires massive metabolic resources.
Yeah, that's it.
It has to be aggressively driving angiogenesis to supply that expanding cellular mass. And that immediately signals to the clinical oncology team that they are dealing with a high-grade, fast-paced biology.
Yeah, this is completely distinct from, say, indolent lipomatous tumors that might just sit there unchanged for years. In fact, the metabolic demand is so extreme that the tumor frequently outpaces its own newly formed blood supply.
It grows faster than it can feed itself.
Exactly. So when we transition from the clinical presentation to the macroscopic examination of the resected tumor, once it's on the pathology table, this rapid expansion leaves obvious physical evidence.
Well, what does it look like?
Well, macroscopically, these tumors present as large, firm, white to yellow masses with highly infiltrative, ill-defined margins.
So no clean edges.
Right, they lack a true capsule. Instead, they just weave directly into the surrounding skeletal muscle. And because the perimeter is growing faster than the internal vascular network can support, we see widespread ischemia right in the center of the mass.
Ah, so it's dying from the inside out.
Yeah, the WHO actually notes that foci of necrosis, along with myxoid changes, are observed in more than half of all PLS cases.
That extensive necrosis right out of the gate is, well, it's a visual confirmation of that runaway metabolic rate. The tumor is essentially starving its own core. And those myxoid changes, that accumulation of mucopolysaccharide-rich stroma, that has to further complicate the physical landscape for the surgeon.
No, absolutely. The surgeon is dealing with a large, necrotic, poorly circumscribed mass. Getting clean surgical margins is incredibly difficult, sometimes impossible.
But once the mass is out, the burden shifts entirely to the pathologist, right?
It does, and under the microscope, the architectural landscape of PLS is notoriously chaotic.
Chaotic how?
Well, the background is essentially a high-grade, undifferentiated pleomorphic sarcoma. You got spindle cells, multinucleated giant cells arranged in these short fascicles, and extremely large tumor cells with vacuolated cytoplasm.
Just a mess of unregulated growth.
Utterly profound cellular atypia. We see rampant pleomorphism and a really high mitotic count, including frequent atypical mitotic figures.
Which just confirms the unregulated cellular division.
Exactly. However, to definitively diagnose pleomorphic liposarcoma, to separate it from just a generic, undifferentiated pleomorphic sarcoma, the pathologist is bound by a strict essential diagnostic criterion.
Right, the absolute requirement of finding pleomorphic lipoblasts.
Yes. These are distinct cells characterized by a multivacuolated cytoplasm that acutely indents or scallops a hyperchromatic pleomorphic nucleus.
So they look very specific.
They do. They're the definitive morphological proof of the tumor's lipogenic origin.
But see, the WHO guidelines are very explicit about this requirement, but they include a really critical caveat.
They do.
The sources state that while pleomorphic lipoblasts are necessary for the diagnosis, their number varies considerably between cases, and crucially, between different areas within the same tumor.
Yes, that's the tricky part.
So if the entire diagnosis hinges on finding these specific lipoblasts, but they're sparsely scattered across a 10-centimeter necrotic mass, isn't that like looking for a needle in a haystack?
It really is.
I mean, what happens if the pathologist just doesn't sample enough of the tumor? It sounds less like finding a needle in a haystack and more like trying to determine what a 10,000-piece jigsaw puzzle depicts when you're only allowed to look at 3 random pieces.
What's fascinating here is that you've hit on the exact vulnerability in diagnosing PLS. The clinical consequence of that sampling error is severe.
I would imagine.
The WHO issues a very strong warning here. Adequate and extensive sampling is paramount. If a pathologist receives a large, mostly necrotic tumor and only takes a few standard sections, they'll probably only see the high-grade spindle and giant cells.
And they'll miss the lipoblasts completely.
Exactly. They will miss those localized clusters of pleomorphic lipoblasts entirely. And without that morphological evidence of adipocytic differentiation, the tumor gets misclassified as an undifferentiated pleomorphic sarcoma.
Which is a huge problem.
A massive problem. In the realm of clinical oncology, that misclassification alters the patient's eligibility for specific clinical trials. It shifts the prognostic models, and it can fundamentally change the therapeutic roadmap.
So the pathology protocol requires exhaustive mapping of the gross specimen just to mitigate this risk.
It has to.
Because the visual landscape is that unreliable and heterogeneous, the pathologist's safety net has to be the tumor's molecular and genetic profile, right?
That's the backup, yes.
If morphology leaves room for doubt, we have to look at the DNA. But moving from the cellular architecture to the genomic profile of PLS, it doesn't really offer the clarity of a single targetable mutation, does it?
Not at all. The genetic sequencing reveals absolute chromosomal anarchy.
Anarchy.
Pure anarchy. The metaphase cells show high chromosomal counts, profound polyploidy, and incredibly complex structural rearrangements.
So the chromosomes are just shattered and stitched back together incorrectly.
Basically, yeah. There are unidentifiable marker chromosomes and non-clonal aberrations everywhere.
But unlike many other soft tissue sarcomas that are driven by a pathognomonic structural rearrangement, a specific recurrent translocation that initiates the oncogenesis PLS lacks any single defining fusion gene.
Right. It's driven by pervasive, catastrophic chromosomal imbalances instead. However, the genomic profiling does reveal frequent mutations in specific tumor suppressor genes.
TP53 and NF1.
Exactly. And the loss of TP53 function is huge. It removes the critical G1S cell cycle checkpoint and basically disables the cell's apoptotic pathways.
Meaning the cell forgets how to die.
Precisely. It allows cells with massive DNA damage to just continue dividing. This directly fuels the polyploidy and intercellular heterogeneity we see under the microscope.
And then the NF1 mutation adds an entirely different layer of uncontrolled growth.
Oh, yeah.
Because NF1 encodes neurofibromin, which normally acts as a crucial negative regulator like a biological brake on the RAS-MAP-PK signaling pathway.
Yep, it keeps the growth signals in check.
So when NF1 is mutated or lost, that brake just snaps. The RES pathway gets stuck in the on position, flooding the cell with continuous proliferation signals.
And when you combine those two things, the constant growth signal from the NF1 loss with the complete absence of DNA repair or apoptosis from the TP53 loss, you get the exact high-grade, fast-paced malignancy we see clinically.
It's a perfect storm.
It really is. The combination of those two mutated pathways guarantees a highly aggressive phenotype. But from a diagnostic pathology standpoint, it is actually what pleomorphic liposarcoma lacks molecularly that provides the most utility.
Here's where it gets really interesting because the most challenging differential diagnosis for PLS is often a dedifferentiated liposarcoma, right?
Yes, specifically one that happens to exhibit homologous lipoblastic differentiation.
Hmm.
Morphologically, under the microscope, they can look remarkably similar in certain focal areas.
So how do you tell them apart?
Pathologists rely on the molecular signatures of the 12q14q15 chromosomal region.
Right. Because dedifferentiated liposarcomas have a very specific, readable genomic barcode, the consistent amplification of that 12q14q15 region.
Exactly. When you run immunohistochemistry, or MIT, on a dedifferentiated liposarcoma, it lights up for MDM2 and CDK4 overexpression.
But pleomorphic liposarcoma's barcode is completely smashed.
Dashed to pieces.
It lacks that 12q14q15 amplification entirely. The WHO criteria explicitly state that staining for MDM2 and CDK4 in PLS is typically negative.
Right. The scanner isn't just failing to read the barcode, it's confirming that this tumor belongs to a completely different molecular lineage.
Ah, okay.
The absence of MDM2 amplification is the definitive compass that steers the pathologist away from dedifferentiated liposarcoma and confirms PLS.
That makes sense.
Yeah, molecularly and genetically, pleomorphic liposarcoma actually clusters much more closely with other high-grade pleomorphic sarcomas than it does with atypical lipomatous tumors or well-differentiated liposarcomas.
Despite its lipogenic morphology.
Right. Its genetic behavior is that of an undifferentiated chaotic malignancy.
So it originates from the adipocytic lineage, but its genetic profile aligns with the most aggressive sarcomas we face.
Unfortunately, yes.
And this molecular reality translates directly into the prognostic data, bringing us from the pathology bench right back to the oncology clinic.
And the biological behavior dictated by this genetic chaos is just unforgiving. The WHO explicitly defines PLS as a highly aggressive sarcoma.
Because of those infiltrative, ill-defined margins we discussed earlier.
Yeah, they result in a high rate of local recurrence. Even with a really aggressive surgical resection, the tumor frequently recurs right in the primary tumor bed.
But the local control is only a fraction of the clinical challenge, isn't it? Because the data shows a metastatic rate of 30 to 50%.
30 to 50%, yeah. The sheer volume of atypical mitosis and the rapid neovascularization, it just provides the perfect environment for vascular invasion.
The tumor literally builds highways for itself to spread.
It does. And we see a highly specific tropism in where those metastases seed. PLS predominantly metastasizes to the lungs and the pleura.
The lungs. Always the lungs.
Always. And this isn't random. It is dictated by the anatomical routing of the circulatory system.
Right, because the majority of these tumors arise in the deep, soft tissues of the lower limbs.
Exactly. So any tumor cells that breach the venous system are carried straight up the inferior vena cava, through the right side of the heart, and pumped directly into the pulmonary capillary bed.
The lungs essentially act as the first massive physiological filter, trapping those circulating tumor cells.
Yeah, the hematogenous spread basically pipelines the metastasis directly to the pulmonary tissue.
And because of this high metastatic rate and the aggressive local recurrences, the overall 5-year survival rate sits at roughly 60%.
Which is sobering. And the clinical guidelines stratify this risk further based on specific prognostic factors.
Right. The odds decrease significantly if the tumor is centrally located rather than on a distal extremity.
Or if there's increased tumor depth, if the overall size is massive, or if the pathologist reports a particularly high mitotic count.
So what does this all mean? We are looking at a patient who presents with a localized mass in their thigh. But does the oncology team have to treat this as a systemic war from day one?
If we connect this to the bigger picture, absolutely. While achieving clear margins during surgery is the foundational first step for local control, the fact that up to half of these tumors have already likely seeded the lungs means the primary battlefield is actually systemic. The oncologist is anticipating and combating micrometastatic disease based entirely on the predictive intelligence gathered by the pathologist's molecular and microscopic analysis.
It really highlights why the multidisciplinary approach is non-negotiable here.
Oh, completely non-negotiable. The surgeon navigates the complex extraction of a necrotic, poorly circumscribed mass.
And then the pathologist exhaustively samples the tissue to secure the morphological proof, finding those pleomorphic lipoblasts while utilizing the negative MDM2 staining to rule out the dedifferentiated mimics.
Right. And then the clinical oncologist synthesizes all that data, the mitotic rate, the tumor depth, the absence of specific fusions to determine the necessity and timing of systemic adjuvant therapies.
Fully aware that the lungs are the most probable site of recurrence.
Exactly.
But we've really tracked the entire clinical life cycle of this disease today. We started with the silent, rapid expansion of a mass in the deep, soft tissue, driven by intense metabolic demand and an outstripped blood supply. We navigated the diagnostic gauntlet, balancing the morphological requirement of finding pleomorphic lipoblasts against the highly chaotic necrotic background. We mapped the genetic landscape, noting how the loss of TP53 and NF1 fuels an aggressive phenotype that lacks the MDM2 amplification seen in other liposarcomas.
And we confronted the clinical outcome, a high-grade malignancy with a strong propensity for hematogenous spread of the lungs, requiring aggressive systemic foresight from the oncology team.
It's an incredible amount of complexity for you to consider.
It is. But, the genomic profile of PLS actually forces us to rethink targeted therapies entirely.
Oh, how so?
Well, we're accustomed to looking for specific targetable mutations, right? Like a clear oncogenic driver.
Right, something we can block with a specific drug.
Exactly. But pleomorphic liposarcoma relies on pervasive chromosomal imbalances and the sheer absence of regulation. It thrives on an environment of constant genetic fracturing. So the question this raises for the future of sarcoma research is whether the pathway to treating these highly complex, target-poor malignancies lies not in attempting to repair the broken DNA or block a specific signaling cascade.
But in utilizing agents that deliberately induce even more genomic instability.
Exactly. Pushing the tumor's already chaotic genome past the threshold of viability until it just undergoes catastrophic mitotic collapse.
That is a fascinating concept, using its own chaos against it.
Exactly.
Well, thank you for joining us in the Tumor Board today, and for bringing your expertise to this exploration of pleomorphic liposarcoma. We will continue to track the intersections of diagnostic pathology and clinical oncology in future analyses. Keep interrogating the data, and we will catch you on the next deep dive.